So this is a topic near and dear to my heart. I spend all day, every day talking about it. It's something I love to talk about. So I'm really excited to be able to be here today to talk about infertility and fertility preservation and kind of getting down to the basics of what I think everybody should know, whether or not you're in a health profession, things that you should know as a person living in this world, male or female. What we'll talk about, so we'll kind of go back to the basics, talk about how a baby's made, what parts go into fertility, evaluating infertility. Specifically, we'll talk about ovarian aging, fertility treatments, and then end talking about fertility preservation. And hopefully we'll have time for questions at the end if any come up. Before we get started, though, I think it's important to highlight why infertility is something that we should be talking about. I think it, for up until recently, it's something that people didn't like to talk about, a sensitive and intimate topic that wasn't talked about outside of the bedroom. And it's something that because of that, people didn't really realize how prevalent or common it is. But infertility is a global issue. It's a medical issue. It affects millions of people. Approximately 1 out of every 6 people experiences infertility in their lifetime. Most people either have experienced infertility themselves or know someone who has. And so it's something that I think that we should be highlighting more and talking more about so that it's less stigmatized and we're more informed and it's less scary that way. I saw a headline just yesterday talking about declining birth rates in the US and in developed nations and declining fertility rates. And the CDC put out this big data update back in April that showed that fertility rates had declined by 3% just over the past year alone. Part of this is potentially because of increasing infertility. Part of it is because of good things like access to contraception and family planning services. So people are delaying or having pregnancies when they want to have that. Women are seeking advanced careers in education and delaying childbearing, which is great. But that does mean as women are getting older, they're trying to have pregnancies later. And with that comes age-related fertility decline, which is something that's tricky to treat. And we'll talk about that kind of at the end when we talk about ovarian aging and fertility preservation. So let's get back to the basics. Let's talk about how to make a baby. I think one thing that's been highlighted in my years of being a physician is that sex education in this country is pretty limited. A lot of people, even very well-educated people, don't have a good understanding of fertility, what's going on in their menstrual cycle, what's going on in their body. So we're going to talk about the basics so you have a good foundation. So what does it take to make a baby? Big picture, you need eggs. Those eggs come from ovaries. 1 egg is released every month in the menstrual cycle, which we'll talk about in a minute. That egg needs to meet with sperm. Sperm comes from a testicle, comes from usually a male partner. When the egg and the sperm meet, the egg and the sperm have to be able to meet. So you have to have an open reproductive tract, usually open fallopian tubes. The egg and the sperm meet in the fallopian tube and they have to be able to fertilize. They have to have the right genetic blueprint to grow into an embryo. That embryo travels into the uterus and it has to be able to implant into the uterus. So you need to have a uterus that is capable of carrying a pregnancy. And then finally, last but certainly not least, you need a human body that can carry that uterus, carry that pregnancy, and be healthy enough to nurture that pregnancy as it grows and develops. So that's a lot of things. It's a complicated process. I think we spend a lot of our life trying not to get pregnant when we don't want to be pregnant, but we forget that it's actually also pretty complicated to get pregnant. And I think a lot of people have an overinflated sense of how easy it is to conceive. Even in the most fertile couples, the likelihood of getting pregnant per month is only about 20 to 30%. And that's the most fertile couples. So most couples are going to be less than that. Time to pregnancy for the average, most couples, so heterosexual couple trying to conceive, about 57% will get pregnant after 3 months of trying. About 72% will get pregnant after 6 months of trying, and then about 85% will get pregnant after a year of trying. An additional 8%, so up to 93% will get pregnant after 2 years of trying, but because there is that kind of diminishing returns after 1 year, that's why we set 1 year as kind of this definition of infertility. If you've been trying on your own for more than a year, it's considered infertility, and that's when we start doing workups and testing, although there may be indications to do workup and testing earlier, depending on a number of factors, age, underlying health conditions, etc. Before we can talk about, well, while we're talking about fertility, I think it's really important to understand the menstrual cycle, to understand how fertility is timed and how you can get pregnant naturally. So this is my favorite thing to talk about. I could talk about the menstrual cycle all day, every day. I will limit myself and try to give you guys just a big overview and not get into too much detail. But I think it's a really important thing to understand. The menstrual cycle, your period, for us OBGYNs, it's like a vital sign. It's an important understanding of how many parts of your body are working together, the hypothalamic pituitary axis, the ovaries, the uterus, all working together to make this happen. It's pretty amazing. So this is how the body releases eggs from the ovaries, basically. So this is what's happening on the hormone level, coming from the brain. This is what's happening in the ovaries, and this is what's happening in the uterus. This is an arbitrarily 28-day cycle. We say that's the average cycle length, although it's very normal to have cycles ranging from 25 days to 32 days. There can be some variability. Most people do not have exactly 28-day cycles. We define cycle day 1 as the first day of your period, and that's typically when things are the most quiet and baseline in the ovaries. So your brain releases a hormone called follicle stimulating hormone that goes to the ovaries to stimulate the ovaries to grow and mature a follicle. Key to hormones is that they often tell you exactly what they do. Makes my job a lot easier. So follicle stimulating hormone tells the ovary to grow and mature a follicle. Each follicle has an egg inside, and so that egg grows and matures as that follicle gets bigger. As that follicle grows, it also releases a hormone called estrogen. Estrogen tells your endometrial lining to grow and thicken and prepare for a pregnancy. And it also gives feedback to the brain to let the brain know when that egg is mature. When that estrogen reaches a certain threshold, the brain releases another hormone called LH, which is the ovulation hormone, luteinizing hormone, in a big spike that stimulates ovulation. So that LH spike tells the ovary to release that egg. That egg is released to meet with a sperm or not. And the place in the ovary where that egg was growing turns into something called a corpus luteum, which is a specialized cyst that produces progesterone. Progesterone, pro-gestation, pro-pregnancy, is the hormone that's essential for embryo implantation into the uterus and supporting an early pregnancy, or really supporting an entire pregnancy. So that stabilizes the endometrial lining, prepares it for pregnancy, and supports a pregnancy as the pregnancy grows. That corpus luteum has a lifespan of 14 days. After 14 days, if there is a pregnancy, the HCG from the pregnancy keeps the corpus luteum alive, and so it continues to produce progesterone to keep the pregnancy going. If there's no pregnancy, that corpus luteum dies, the progesterone levels drop off, and that drop in progesterone tells your endometrial lining to shed, you get a period, and the whole cycle starts over again. So that's what's happening in the body. You only see the period happening, but there's a lot going on the rest of that month outside of just that period. So you're only releasing one egg a month. Now, that egg only lasts for about 12 to 24 hours after ovulation. So it's only around for a very short period of time. Sperm, on the other hand, can last in the reproductive tract for 3 to 5 days. So if you're trying to get pregnant, you really want to have that sperm getting to the egg or getting into the uterus and the reproductive tract before the egg gets there. Your most fertile days are going to be the 3 to 5 days leading up to ovulation, with the day of ovulation being peak fertility. After ovulation, it's too late to have intercourse to try and reproduce. At that point, I tell people intercourse is just for fun. So it's really the days leading up to ovulation that is going to be the most fertile days, with that day of ovulation being the most fertile. Ideally, I tell couples to try to have intercourse every other day or every day during that window. Sometimes people, if you have regular predictable monthly cycles, you can use your cycle length to predict when ovulation is going to be. It's going to be about 14 days before your next period. Other times, if you have unpredictable cycles, people will use things like ovulation predictor kits, which measure LH in the urine to help figure out when that ovulation happens. So that's how to get pregnant on your own, how to time pregnancy, time intercourse to try and conceive naturally. Now, a common question I get is, how can I optimize things lifestyle-wise for pregnancy? And I think it's a good question. It's a hard question to answer because it's a hard thing to study, but there's some things that we do know. People often ask me about diet. There are many fertility diets out there, things claiming that they're going to give you peak fertility. There's this one, the fertility diet out of Harvard School of Public Health that was based on findings from the Nurses' Health Study, has some interesting research-backed data. I think the big thing to take away is that all of these diets kind of come down to one thing. Things that are healthy for your body are healthy for your fertility. You want to be eating a balanced diet, nothing that is overly restrictive, getting all the vitamins, nutrients, and components of a healthy diet that you need. So healthy fats over trans fats, vegetables, and unprocessed food over animal protein sources, low glycemic index carbohydrates, making sure you're getting all the vitamins you need, prenatal vitamin with folic acid, most people need, sufficient iron. There is some data behind the Mediterranean diet. I think really that's just because the Mediterranean diet is a very balanced, healthy diet. Other lifestyle things to consider. So smoking, we know that smoking is really bad, but we know it's bad for your health in general. We know it's really bad for fertility. So if you need another reason to quit smoking or avoid smoking, I hope fertility can be one of them. Women who smoke are significantly more likely to be infertile. Menopause occurs 1 to 4 years earlier in those who smoke, and there's an increased risk of miscarriage. It also affects male fertility as well. Alcohol. We don't recommend women drink while pregnant. There's no safe amount of alcohol to consume, but in times leading up to pregnancy, moderate amount of alcohol is less than 1 drink on average per day for women. Caffeine, you don't have to cut out coffee completely when you're trying to conceive. Studies have shown that less than 200 milligrams of caffeine is shown to be safe in pregnancy and when trying to conceive. So high amounts of caffeine intake can be associated with increased risk of miscarriage, but usually that's more than 500 milligrams a day. And finally, cannabis. That's a tricky one we're learning more about. There are definitely notable impacts of cannabis on semen parameters and male fertility, and probably some decreased fertility in women, although it's some studies show it, some studies don't. It's less concrete. So let's move on to talking about infertility and how we evaluate for infertility and causes of infertility. So the definition of infertility for many years was defined as trying to conceive for over 12 months, or a heterosexual couple trying to conceive unprotected for over 12 months in those with a female partner under 35 years of age, and for greater than 6 months with a female partner of over 35 years of age. The reason there's that discrepancy in under and over 35 is not because we expect it to be faster when you're over 35, but it's rather the opposite. It probably will take longer when you're over 35. But because of ovarian aging, we just don't want people over 35 waiting too long to get an intervention, because age of the egg is a continuing process that we can't reverse. Now, this definition was not very inclusive. There are many couples and people that don't fit into that cookie cutter, that mold and that description. And so in 2023, ASRM, the American Society for Reproductive Medicine, actually expanded the definition of infertility, which I think is amazing, to also include the inability to conceive based on a patient's medical, sexual, and reproductive history, age, physical findings, and diagnostic testing. So you don't have to try for a year purely to try for a year. If there is something evident in your history and your setup that makes it so that you can't get pregnant, you're in a same-sex relationship and you don't have eggs, or you don't have sperm, or you don't have a uterus, your fallopian tubes are blocked and you know it, you shouldn't have to wait a year of trying before getting fertility treatment. And this is a big thing. Really, it's for insurance companies. A lot of insurance companies use these definitions to deny care or not offer care until someone has met certain criteria. And so we're hoping that with this new definition, coverage will be expanded and be more inclusive, as it should be. So when we were talking about the things you need to make a baby, basically things can go wrong at every aspect of that process, and can cause fertility issues. Causes of infertility in couples. So about 1/3 of the time is tubal factors or pelvic pathology. So blocked fallopian tubes, scarring in the abdomen. That blocked fallopian tubes block those eggs and sperm from meeting. Male fertility problems or absence of a sperm source, abnormal sperm parameters in about 1/3 of couples with infertility. Ovulatory dysfunction in about 15%, and then unexplained infertility in 10%. And this is, actually, in my experience, it's probably higher than this. This is one of the trickiest causes of infertility, because So it's unexplained in that we do all of our testing and we don't find a reason why people are having trouble getting pregnant. It doesn't mean there's nothing wrong. Honestly, I think it probably means that our testing just isn't sophisticated enough to find the problem. So we don't know what the answer is. We just, we don't have the technology, we don't have the testing to be able to know. You can see so looking at females only, that the tubal pathology is about 40% and ovulatory dysfunction is about 40%. So how do we work up infertility? What testing do we have? Big important thing to understand is that there's not one fertility test. I often get people coming into my clinic saying, I want to get my fertility tested. I want to know if I can have a baby and if I can have a baby in 5 years. And, we don't have one test other than trying to conceive because it is a really complex process. So we test every part of that process that we can, and then we go from there. So I know this is Women's Health Week, but making a baby takes two. So important to remember the sperm component of this, the male component of this. The assessment for male factor fertility is a semen analysis. It's basically looking at an ejaculate under a microscope, assessing the volume, the concentration of sperm within that ejaculate, the number of sperm, the morphology, so how that sperm looks, and the motility, how that sperm is moving. And there are cutoffs for normal and abnormal. Unlike women, men make sperm throughout their lifespan every day. They make millions a day. They can emit that sperm, usually whenever they want. So there's a little more wiggle room when it comes to sperm, but sperm factors impact fertility just as often as egg factors. So it's an important thing to assess if you're having trouble getting pregnant. The next category that we look at is tubal testing. So testing to make sure those fallopian tubes are open. Now, fallopian tubes are really small. I can't see them on a regular ultrasound. In order to see if a fallopian tube is open, we have to put dye into the uterus and then see if that dye comes out through the fallopian tubes. A classic way of doing it is with something, well, I should say actually the gold standard of doing it is in a surgery, a laparoscopy, where we look in the belly with a camera, put a dye in through the uterus and see that dye come out. Now, we don't want everyone to have a surgery just to have a diagnosis. So there are other tools we use. The classic way is something called a hysterosalpingogram or an HSG. That's using dye and an X-ray. Here at UCSF, that's done with radiology. Now, more and more, I'm moving towards an ultrasound tool. What we do here is called a hyphosi. It's the same idea. It's a foam that's white on ultrasound. We put the foam into the uterus and I do an ultrasound to see if it comes out through the fallopian tubes. They can be a little uncomfortable to do. It has to be done at a specific time in a woman's menstrual cycle. So there's some limitation in that. But they actually have done studies that show that fertility is slightly higher the month that you have tubal testing done. So I always tell my patients to try extra hard that month, just because it can boost things a little bit. Things that can cause blockage in fallopian tubes are any sort of pelvic infection. So STIs are pretty common, gonorrhea, chlamydia, usually major infections leading to like pelvic inflammatory disorder, but even a minor infection that's treated can cause some minor damage in the tubes that can cause tubal abnormalities. Other causes are any intra-abdominal surgery or major infection like a ruptured appendix, surgery that can cause scar tissue, and then finally endometriosis can cause scarring in the abdomen that can block the fallopian tubes. Another category of testing that you might get if you come into my office with infertility, wanting to work that up, is hormonal testing. Now, I don't do all of this hormonal testing on everybody. I do it based on your history, based on your presentation, oftentimes based on your menstrual cycle. So if menstrual cycles are irregular, I'll be looking at hormonal causes of that and doing more of this testing, specifically testing for PCOS or testing gonadotropins to look for ovulation. Thyroid function. This is kind of part of that. The human body needs to be healthy enough to carry a pregnancy. So we want to make sure that the whole body is healthy and functioning. And finally, uterus evaluation. So you need a uterus that can carry a pregnancy. Things that can make it harder for a uterus to carry a pregnancy can be large fibroids, structural anomalies in the uterus. Some of those we can assess with a regular transvaginal ultrasound. So this is a transvaginal ultrasound. This is the uterus here. This darker gray is the muscle of the uterus. The lighter gray is the endometrial lining. But a regular vaginal ultrasound looks at kind of the outside of the uterus. It doesn't evaluate the cavity of the uterus where a pregnancy would go. So some people need a more specific test. That's where a saline sonogram comes in. It's a specialized ultrasound where we put fluid in the uterus, open the uterine walls so we can evaluate the cavity a little more. And you can see here, this is the muscle of the uterus. This black is that fluid kind of opening up those uterine walls. So it would be like the fluid kind of coming in here on this picture. And you can see, is there a fibroid that's coming in, distorting the uterine cavity? Is there a structural anomaly that might make it harder for that uterus to carry a pregnancy? So that's the fertility workup. I think an important thing that we didn't talk about is the ovary and the eggs. It's a pretty essential part of the fertility picture. And before we talk about that, I want to talk about ovarian aging. So you may have heard that fertility declines with age. I think it's something we, especially women, hear a lot, this ticking clock in the back of our head. But I don't think we talk a lot about what that actually means and what that looks like. So we've known that fertility declines with female age or age of the egg, I should say, for a long time. Back in the 1920s and 30s, when they were first starting to understand fertility, they studied a population of people called the Huterites who basically didn't believe in contraception, tried to reproduce as much as possible. And in that group, they found that birth rates declined gradually in the 20s and early 30s, and then more significantly after 35, with very few people after the age of 40 having babies, and really after the age of 45 having babies. So we know that in natural populations, fertility declines with aging eggs. And we've actually seen that reproduced in fertility treatment. So live birth rates per ART, assisted reproductive technology cycle, so that's like IVF cycles, declines with age, somewhat up until the age of 35, and then more drastically after the age of 35. So we've seen it even with our fertility treatments. Fertility treatments don't overcome age-related fertility decline. So why is that? It's really because we're born with all of our eggs. So you have the most number of eggs you'll ever have when you are 20 weeks gestation in your mother's uterus. You have about 7 million eggs at that point. By birth, that number has gone down to 1 to 2 million. By puberty, you have about 300,000 to 500,000. And then by the time you hit menopause, you're down to less than 1,000 eggs. And so the number of eggs we have declines with time, and your body is constantly going through eggs, not just through ovulating, but constantly going through eggs. I think we think a lot about that number and the number as it relates to fertility, because it's an easy thing to wrap your head around. When you run out of eggs, you can't get pregnant anymore, you go through menopause. And we have tests to assess the quantity of eggs that you have, to assess your ovarian reserve. That's testing for the number of eggs left in your ovaries. So the two tests we have to look for that are antral follicle count, which is, so this is an ovary. Each of these circles is an antral follicle. Each one has an egg in it. The number of every month your body matures a group of eggs to that antral follicle level. One of those ovulates all the way, the rest die off, and a new group grows. And the number of antral follicles month to month is roughly the same, but declines with time as the total number of eggs in your ovaries goes down. So the antral follicle count in that way is reflective of the total number of eggs in your ovaries. Doesn't mean the total number of eggs, but it's reflective of that. So we can do an ultrasound, we can count your antral follicle count, and that gives us a sense of your ovarian reserve. We can do a blood test for a hormone called anti-Müllerian hormone, or AMH, which is a hormone that comes from, well, really the eggs right before this, but kind of comes from this pool of eggs, and so also is reflective of that ovarian reserve. If your AMH is higher, you have a higher ovarian reserve than if your AMH is lower. If your AMH is lower, you're closer to menopause than if your AMH is higher. So we can assess quantity. Now, unfortunately, quantity is not predictive of natural fertility that much until it gets to zero. It's kind of a binary. So, you know, as long as you have some eggs left, whether you have an ovarian reserve in the 95th percentile or an ovarian reserve in the 5th percentile, as long as you have some eggs left, you're still only releasing 1 egg per month, and that is the limiting factor. So they've done studies that AMH does not predict natural fertility unless it's zero and you're not ovulating anymore. So it's not exactly the fertility test that I think a lot of people think it is. It's helpful information to have, but it is not perfect information. What it's most reflective of is how many eggs we can get in an IVF cycle and your response to ovarian stimulation and our kind of the efficiency of our fertility treatments. But it's not going to test your natural fertility. What impacts natural fertility more when it comes to aging is the quality of the eggs. And when we're talking about, not only does the quantity decline with time, but the quality declines with time. And when we're talking about the quality, we're talking about actually the genetics of the egg on a chromosome number. So not genetics like, I have blue eyes, my kids might have blue eyes. Genetics on big chunks of genetic information. So if your entire chromosome, if your entire genome is a book, the chromosomes are like chapters of the book, big chunks. As women age, a larger percentage of their eggs become aneuploid or have an abnormal number of chromosome. Here is a normal chromosome number, 46. Here is an abnormal number of chromosomes. So this karyotype has an extra 10 chromosomes, so an abnormal number of chromosomes. And I think of that as just not having the right blueprint to make a baby. It doesn't have the right, so an egg that is aneuploid, most of the time it's not going to fertilize. If it's fertilizes, it's more likely to result in a miscarriage. Rarely it can make a baby with chromosomal abnormalities like trisomy 21, which is Down syndrome. So all of those things increase as women get older or as eggs get older. But the vast majority of the time, it won't make it that far. It just won't fertilize. So why does this happen? It happens because of non-disjunction and meiosis. And so for the scientists out there, or people who remember back to their high school biology when you learned meiosis, eggs are halted at a certain stage, and in order to mature all the way and be fertilized, they have to complete meiosis. And basically the cellular machinery as we age doesn't work as well. And so instead of chromosomes splitting evenly, you get one egg with more chromosomes and one egg with fewer chromosomes. You get abnormal splitting of those chromosomes because of aging in the cellular machinery. We unfortunately don't have a way of testing for egg quality. So while we can test for egg quantity with ovarian reserve, that does not reflect egg quality. And egg quality, we don't have a test for. I can't do a blood test and say, you have 70% normal eggs. And I can't, even when we get the eggs out of the body, we can't test the quality because an egg is only one cell. So we don't have a way of assessing the genetics of it without destroying that egg. But we can test embryos and have, from testing lots of embryos, have learned that the genetics, the aneuploid or euploid, or the ploidy status of the embryo, it comes from oftentimes the ploidy status of the egg. And so this is from a large study where they tested many, many embryos. And what you can see, this is the percentage of embryos that are aneuploid based on the age of the egg source. You can see that roughly 30% of embryos are abnormal for people in their 20s and early 30s. And then again, we see this inflection point at 35. It's not that you hit 35 and your ovaries shrivel up and die, or you fall off a cliff, but there is an inflection point where there is an increase in the number of abnormal eggs, an increase in aneuploidy, and thus an increase in aneuploid embryos that happens. At 40, it's going to be closer to 70% of embryos produced are aneuploid. By 42, 43, it's going to be closer to 80 to 90%. And that's why it gets harder to get pregnant as you get older. Now, unfortunately, and so with that, you see that fertility rates decline as women get older, and miscarriage rates increase because the most common cause of miscarriage is aneuploidy in an embryo. So sometimes they make an embryo, they implant, but it just, again, doesn't have that blueprint to make it all the way, make it to a live birth. So all of these things together make it harder for people to get pregnant as they get older. Now, that doesn't mean you can't get pregnant. We all have heard of people or have friends or may have been those people who had a baby at age 40, but it's just harder for that to happen. It doesn't happen for as many people. And unfortunately, we don't have good treatments to overcome it. So we don't have a way of making more eggs. We don't have a way of making better eggs. And we don't even really have a way of finding the good eggs in the ovaries. All we have is the ability to get your ovaries to put out eggs to a certain point, put out more eggs, hoping that in putting out more eggs, we get to a good one faster. But it's not a very specific or a very targeted treatment. We can do so much better. We just don't have the technology yet. So that brings us to fertility treatments. Most of the time, our treatments tie back to that workup. So, and the cause of infertility. So if we have a clear cause for the infertility, we will treat that cause. If there's a fibroid, we'll take out the fibroid. If the fallopian tubes are blocked, we can do IVF, in vitro fertilization, to bypass the fallopian tubes. If sperm counts are low, we increase concentration of sperm, either by putting sperm directly in the uterus with intrauterine insemination, or taking sperm and injecting it into the eggs so we can do more with fewer sperm. So there are treatments. If there's a clear problem, we treat that problem. Now, if you are in the case of unexplained infertility or even age-related infertility, where we don't have a clear explanation for what's going on, then our treatments are really aimed at increasing number of eggs. So instead of 1 egg per month, trying to stimulate the ovaries to put out more eggs, either with ovulation induction using pills like Clomid or Letrozole, where we can get the ovaries to put out maybe 2 to 3 eggs at a time, or controlled ovarian hyperstimulation, where we give injectable hormones to try to get the ovaries to produce more eggs and remove those from the body, usually with IVF. And then getting sperm closer to the eggs, more sperm closer to the eggs. So intrauterine insemination concentrates sperm, puts it into the uterus. So you're getting more sperm closer to the eggs at the time of ovulation. In vitro fertilization, or IVF, we actually take the sperm and put it into the eggs. So you need 1 egg to fertilize an egg instead, or 1 sperm to fertilize an egg instead of thousands of sperm. There are different combinations of how we use these depending on people's diagnosis. So I want to talk a little bit more about IVF, because I think that's something that people are curious about, people don't understand or don't know as much about, and it's a lot of what we do. So IVF, in vitro fertilization, is really the main idea is we stimulate the ovaries to grow and produce more eggs. We remove those eggs from the body. We fertilize those eggs outside of the body in a lab. We grow hopefully those fertilized eggs into embryos, and then put embryos back in the uterus, usually 1 at a time. So in that, we're getting more eggs out, we're bypassing the fallopian tube. It can help fertility in a lot of different ways. What does that look like? So it all starts with ovarian stimulation. And one thing I will say is that ovarian stimulation, we have 1 tool to get eggs out of the ovaries. Ovarian stimulation is the same whether you're freezing eggs, freezing embryos, or doing IVF to get pregnant now. It is 1 process. And it just, egg freezing is just you're doing only the egg retrieval part now and then pausing and doing the rest of it later. So it's the same process. We're just doing different parts of it at different times depending on your needs. So ovarian stimulation is basically trying to hijack our natural menstrual cycle and supercharge it. So a normal menstrual cycle, the brain, as we talked about earlier, remember back to our menstrual cycle, I told you I like to talk about it. The brain releases a hormone called FSH, follicle stimulating hormone, to the ovary to grow and mature 1 egg. In ovarian stimulation, we are giving that hormone in much higher doses through injections to try to get the ovaries to grow and mature more eggs. Now, we can't grow just any eggs in the ovaries. Most eggs in the ovaries are not responsive to FSH because they're too immature. But as I said, every month a group grows to that antral follicle stage, and those are the ones that can respond to FSH. And so in that way, your antral follicle count dictates how many eggs we can get in an IVF cycle. If your antral follicle count is 20, then we can get 15 to 20 eggs in 1 cycle or 1 month. If your follicle count is 5, then we can get 3 to 5 eggs in a cycle. I can't get more eggs than the number of follicles you have. And so that's where ovarian reserve really plays into the efficiency of our treatments. I think another important part about this is a common question I get is, well, if I'm doing ovarian stimulation for anything, egg freezing, IVF, am I reducing my ovarian reserve? Am I going to go through menopause sooner? The answer is no, because I'm not tapping into your reserve for next month. I'm rescuing eggs that otherwise wouldn't have been used. So instead of usually 1 egg ovulates and the rest die off, in ovarian stimulation, we're trying to go all of those eggs. And so it's not reducing fertility for the future. What does that look like? So there are a lot of different protocols that we can use. Generally, it involves about 10 to 12 days of injections, usually 2 to 3 injections a day that people are giving themselves at home. You come in for vaginal ultrasounds and blood tests about 5 to 6 times during that period to monitor the hormone levels and how those eggs are growing. And then when we think we have as many in the mature range as we can get, when we think they're ready to be harvested, we do a trigger shot to trigger that final maturation. It's mimicking your body's LH surge that we talked about earlier. And 36 hours later, you come in for your egg retrieval, which is done under anesthesia, done vaginally. So the egg retrieval takes about 10 or 15 minutes. It's about as minimally invasive as a procedure can get. It's a small needle that goes over the vaginal ultrasound, through the vaginal wall and into the ovary, and suctions out those eggs from the ovaries. The eggs then go to the lab where they kind of do their magic in the back. The eggs look like this. So this is an egg with the cumulus cells, the kind of support nurturing cells around the egg. For some parts of fertility treatments, we'll strip off those cells, and this is what the egg looks like, what a mature egg looks like. It's one cell, as I said. Then, if you're freezing eggs, we would freeze the eggs at this point. We'd strip the cells and freeze them at this point, and you would pause, and then you could do the rest of this later in the future. If you're trying to get pregnant, doing fertility treatments, the next step is to fertilize the eggs, to combine the egg and the sperm. We have two ways of doing that. Conventional insemination is putting sperm around the egg and letting it fertilize how it would in the body. Intracytoplasmic sperm injection is picking one sperm and injecting it to the egg. So it's really helpful for people who have very abnormal semen parameters, who are limited in the number of sperm that they have. You can pick the one that looks the best and put it in. So you can see, and this is kind of a cool picture here. So this is that egg again. This right here in that needle is the sperm. So you can see how much bigger the egg is than the sperm. Once the egg and the sperm combine, we grow them into an embryo in the laboratory, usually for 3 to 5 days. Sometimes we transfer the embryos back on day 3. Sometimes we grow them to day 5. There are pros and cons of each that are beyond the scope of this talk. At the day 5 stage, the blastocyst stage, we do have the option of genetically testing the embryo. So that can be used for people who carry genetic disorders like cystic fibrosis that they don't want to pass on to their children, specific genetic disorders. We can test the embryos for that. Once we have an embryo, we usually transfer the best embryo, typically one at a time, back into the uterus. So this is what a blastocyst embryo looks like. This is actually a beautiful blastocyst embryo under a microscope. Putting the embryo back in is pretty straightforward. It feels like a pap smear. It's a speculum exam, a small catheter that goes through the cervix into the uterus, and the embryo is placed up at the top. Now, the uterus is only receptive to an embryo at a very narrow window in the menstrual cycle, like 1 day out of the month. And so we have to be specific in how we put that back and when we put it back in the uterus. We can't just put it back at any time. And then you wait and hope that the pregnancy takes and the embryo implants. Not every embryo will implant, or I should say, not every egg makes an embryo. Not every embryo makes a baby. Again, a lot of things go into this process. And so there are a lot of things that can affect the chance of success. For a blastocyst embryo, chance of implantation per embryo is about 50% for people under 35. Chances go down as women age because of that aging egg. I think an important thing to also talk about, so there are many ways to make a family. We talked about, and there are many fertility treatments that we do here outside of just IVF, or using IVF to help in a number of different scenarios. So a lot of couples come to us wanting to use donor egg or donor sperm insemination. Sometimes that's because they're in a same-sex couple and they don't have that gamete. They don't have maybe a same-sex female couple. They don't have sperm, or as part of their couple, they don't have that gamete. They need a donor. Sometimes it's because of ovarian failure, premature menopause. They need an egg donor because they don't have eggs of their own. Sometimes it's because they want to be a parent without a partner. And so they have, they have eggs, they have sperm, they need the other. And so we can help with that. And those are kind of those causes of infertility. I mean, if infertility, if you're thinking of it as not being able to have a baby, those are causes of infertility that maybe aren't pathologic or disease processes that weren't captured in that original definition of infertility, but certainly can make it harder for people to have a baby, and things that we can help with at our clinic with our technology. Another thing that we do is gestational carriers. So a gestational carrier, which used to be referred to as a surrogate, now we use the term gestational carrier, is basically a uterine source. So a person who has a uterus who will carry a pregnancy for another couple using another egg source and another sperm source. Reasons for doing that are people who have endometrial receptivity issues or uterine abnormalities that are making them not be able to get pregnant or have miscarriages. Or if you had, some people are born without a uterus, something called MRKH. There are uterine anomalies that can make it harder for people to be pregnant, or you might have had a medical issue like a delivery, heavy bleeding, needed to have a hysterectomy for some reason. A gestational carrier can help those people have a family. And then again, certain couples that just don't have a uterus as part of their anatomy, a gestational carrier can help with that. So there are lots of ways to make a family, and we build families of all kinds, and these are really special ways that we can use our technology. So finally, after talking about fertility, I want to talk about fertility preservation briefly, because I think, when I talked about ovarian aging, I think it's that kind of gives you this clock, something that people are stressed about. And so I think fertility preservation, egg freezing specifically, is something that is talked a lot more about. And, I think it's important for people to understand what it is, what it can offer, and also what it can't offer, kind of the limitations in it. So fertility preservation, I guess, really what it is doing IVF, doing that first part of IVF, the ovarian stimulation to get the eggs out of the body at a younger age when the ovarian reserve is higher, so you can get more eggs at a time. So the process is more efficient, and the quality of the eggs is higher. So more of the eggs is normal. So really the whole process is more efficient. You're basically, because we haven't figured out, we're not good enough to know how to make more eggs or make better eggs. Fertility preservation is kind of the workaround of that, the getting eggs out of the body, saying, if you're going to need to do IVF in the future, let's do part of it earlier when it's going to be more efficient, so that, because we can't make more eggs later on. Who is it fertility preservation for? So it initially was developed for people who were going to go through treatments that would damage their ovaries. So gonadotoxic treatments like chemotherapy, radiation, surgeries where you needed to remove the ovaries would go through fertility preservation. We used to consider these medical indications. Fertility preservation urgently to try and preserve eggs before those treatments happen, so that if they damage egg reserve, damage egg quality, you have some eggs frozen from then. Now, also it's used more often frequently for people who are going to go through gender affirming hormone therapies, because we know those hormone therapies can cause damage to the ovaries, damage to the eggs. And so similarly, getting eggs out earlier before you start those therapies, so you still have those eggs as an option for reproducing in the future. You have that, genetic gamete of your own. In 2012, the experimental label was taken off of egg freezing, and it was expanded to those who are looking to delay childbearing for many reasons. So, or people who are worried about age-related fertility decline. And so, as I said, this is kind of our workaround for that aging egg that we haven't figured out how to fix. And finally, people with diminished ovarian reserve who might go through an early menopause. It's a way of preserving that fertility if they go through that early menopause. And there are many other reasons people might use fertility preservation, but these are kind of the big ones we think about. We can freeze eggs, or we can freeze embryos. The benefit of eggs is that you have more flexibility. The benefits of embryos are that you know more. So eggs are perfect for people who don't have a partner yet or want maximum flexibility. Once you combine an egg and a sperm, you can't uncombine them. So once you've created an embryo, you can't unfertilize it. And so you are committed to that sperm source. Freezing eggs gives you more optionality. It's less costly because you're doing less of it up front, although you'll have to do the rest of it down the line. And there are fewer legal implications because it's something that you're doing on your own. When people come to my office, I often will say, egg freezing is something that you're doing for yourself. Embryo freezing is something you're doing as a couple. Some people, for religious reasons, if they feel like they wouldn't want to create an embryo that they wouldn't use, might not create embryos. And so that's another reason people might do egg freezing. Now, embryos are good if you're certain about the sperm source. Again, if it's a couple that knows they want to have children together and they're just trying to delay things for themselves. Embryos are slightly harder than eggs. They have a slightly higher survival after the freeze and the thaw, although with recent advancements in freezing eggs and vitrification, eggs survive very well as well. Eggs, we lose about 10 to 15% in the freeze and the thaw, whereas embryos, we lose about 5%. So it ends up being comparable. But the big thing about embryos is that you know more about the embryo. Not every egg makes an embryo. Not every embryo makes a baby. The embryo has jumped through the hoops of fertilization and growing that far. And so you just have more information about it. You can also do genetic testing to know ploidy status and sex. So there's more information about embryos. But it's not a one size fits all. It really depends on your personal situation and your personal goals. What's the ideal number of eggs? So I think big thing to remember is that as I said, not every egg makes an embryo. There's a big drop off from egg to embryo to baby. About 50% of eggs will fertilize normally. About 40% of those will make it to an embryo. And so you need a lot more eggs than the number of babies you want. It's hard to know exactly because there's a lot we don't know about the egg. We can't test the quality of the egg when we freeze them. The egg is also one part of the picture. You don't have the sperm, you don't have the uterus, you don't have the human body that's going to carry all of that. But we do have models that help us give predictions. So generally what this model is showing is the probability of having at least one live birth based on the number of mature eggs frozen and the age at which the egg is frozen. So if you're in this under 35 line here, this red line, if we freeze 20 mature eggs, you'll have about a 90% chance of having a baby. What you can see is the more eggs you freeze, the closer to 100% chance you get, but you're never going to get to 100%. The other thing you can see is that as you age, as the eggs get older, you need more eggs for the same percent chance. So at 36, you're going to need 25 eggs for that same 90% chance. At 37, it's going to be closer to 35 eggs. And that's because of that quality decline with age. Now, important thing to remember is that this is the age of the eggs when you retrieve them, not when you use them. So the eggs, when they're frozen, that quality stays kind of frozen there. The thing to remember, though, is that this is just a model. At the end of the day, you're not going to have 90% of a baby. You're either going to have one or you're going to have zero. You don't get these fractions of a percent. And so it's really important to remember that egg freezing is never a guarantee. It is people bill it as an insurance policy, and I don't love that metaphor because to me, insurance implies a guaranteed payout, although I know insurance doesn't always pay out, but it implies a payout in the end if you need it. I like to think of it more as an emergency savings account. So if you put money into an emergency fund for the future, you may have an emergency and have to use that money. You may not, right? You may freeze eggs and be able to get pregnant on your own, and then you don't need to use them. You may have enough money to cover that emergency. You may not. But the more money you have, the better off you are, and the more likely you are to be able to cover an emergency that comes up in the future. So it's like saving a limited resource. But important to remember that it's never going to be a guarantee, which is why our technologies are just not perfect, and we haven't perfectly figured out how to overcome our biology yet. But we're working on it. We're trying to know. And hopefully a lot of you out there are working on it too. So in conclusion, things I want you to take away from this talk are making a baby is complex. Infertility is more common than you think, and it's a growing problem, especially due to increasing age and delays in childbearing. We can't make more eggs or better eggs, so egg freezing with fertility preservation or embryo freezing offers a workaround to that decline, but it's far from perfect.